Good
Hello.
afternoon or evening.
Good evening. How are you?
Good yourself?
Lovely. Good to see you. Thanks for making it.
No problem.
So, good evening, everyone. Thank you so much for joining. We're to start by 8 o'clock. So we'll just give people about 5 minutes to join. Prof, will you see if you can be able to share your slides? You should be able to, so that you can drive them as you want.
Okay, let me get to them.
Mm.
You can see them now.
Yes, we can. Fantastic. So you'll just put it in share mode or PowerPoint mode, slideshow. Yeah, that's the word.
You mean like this?
Fantastic. Yeah, exactly like that. It's a beautiful skyline.
Yep, it is.
Okay. So far we've capped it at 36 participants, but I'm sure by 8 o'clock people will join. So
What
just give
happened to
me.
the other person that was supposed to speak?
So he just said he was not able to join at this time. I think he got some other commitment. Yes.
At the last minute? Seems a
Well,
little
unfortunate.
strange.
Okay. Yes. Well, we still hope to continue the discussion. I think you have a wealth of knowledge, so I'm sure we'll grill you for the next many minutes.
Okie doke.
All right, let me just make a call and then we'll continue. Ellie's here. Dr. Ellie, can you hear us? Can you unmute?
Let me see. Oh, can you hear me?
Yes, we can hear you.
Oh, it's good to see you, Prof, after a long time.
Been a while, yeah. How you doing?
I'm very well, Prof.
What's new in Nairobi?
Oh, you should come and see for yourself in your next trip.
I don't know, is that good or bad?
It's both, but it's mainly good.
All right. Okay, good. So these are mostly gynecologists from Kenya. Is that where most of these people are?
Yes, we extended the invitation to the Kenya Obstetrics and Gynecology Society. And of course, it's somehow metastasized also to some IGCS fellows and the IJGC Early Career Fellows. And so we are a mix mostly of gynecologists, obstetrics and gynecologists, some fellows, and in surgery, Sajong, I think there was one Sajong fellow. Yeah, just a myriad, but mostly doctors in the field.
Okay.
Oh.
Oops.
Prof, when are you coming back to Kenya, actually? I know you just recently left.
Probably won't be till sometime next spring, maybe.
Oh, wow. I
Um,
think
I have a very busy fall.
so next time we can try and organize that you tour some of the centers where most of us IGCS people are there.
You mean like Mombasa and
Yes, especially Mombasa.
Mombasa,
I'm biased
right?
like that.
Yeah, no, that's fine. I've never been to Mombasa.
Really? After all these years in Kenya?
Yep. Yep.
Oh, goodness. Okay, we need to fix that. That is sacrilege. We cannot have that. So, but you go to Florida a lot, so I'm sure you're used to the beaches and sand or whatnot, but there's something different that
I'm
the
sure
Kenyan
there
coast
is.
offers. Yep.
Yeah, no, I'm sure there is.
Yes. All right, so it's 8 o'clock. I think we'll officially start the meeting. Again, good evening, everyone, and good afternoon, Professor Covens. My name is Dr. Anisa Mburu. I'm a GYN oncologist in Aga Khan Hospital, Mombasa. And we are here with Professor Allan Covens, who is a gynecologic oncologist at the University of Toronto with extensive experience in minimally invasive surgery, fertility sparing surgery, cervical cancer as a whole, and also has quite a history with Kenya. So he understands our situation on the ground. We've had surgeries with him, a lot of classes with him. And for most of the gynecologists in the call, you are aware that he's been one of our international mentors. And so again, we thank you for that and welcome Prof. Covens. So unfortunately, our other speaker, the surgical oncologist, Dr. Shailesh, had to cancel because he had, he had a last minute cancellation, but either way, we are going to proceed on with our discussion. We'll have a presentation from Prof. Covens, and please keep the questions coming. You can put them down on the chat, and once you're done with the presentation, or as we continue with the presentation, just type in your questions, send them in, and I'm sure Prof. Covens will be more than happy to entertain us. All right, so without further ado, Professor Covens, you're on.
Thank you. So it's a pleasure to speak to this large group. I haven't met, I'm guessing, a significant proportion of you that may not be part of the gynecologic oncology training program in Kenya, specifically Eldoret. So I understand the sort of questions and discussion and topic was around surgery for cervical cancer, specifically minimally invasive surgery, which changed dramatically around 2018 at the completion of the LAC trial, which, as I'm sure all of you know, showed a surprising detriment to MIS surgery over open surgery. So I'm just gonna state some provocative things during this talk and help think a little bit more about why this may be the case. So, the LAC trial was a very large, well-conducted trial, and I'm not here to argue the results or debate the results or critique it. There's no such thing as a perfect trial, but it would be hard to not defend the trial on the basis of some methodological issue. So, I mean, in a nutshell, this says it all. This is the disease-specific survival for patients that underwent either MIS or open surgery. And you can see that the hazard ratio is 6.5 times greater for death if you had minimally invasive surgery rather than open surgery. Quite a dramatic, impressive result. However, it's important to recall the eligibility, the predominant patients, and this is taken directly from the discussion or conclusions in that trial. And it specifically says the results of this trial cannot be generalized to patients with so-called low-risk cervical cancer, tumor size under 2 centimeters, no LVSI, minimal depth of invasion, and no lymph node involvement, because this trial was not powered to evaluate the oncologic outcomes of those approaches in that patient population. Because the risks would be lower, you would need a much greater sample size to determine that effect in that population. So the LAC trial did show inferior results for the greater than 2 centimeter cervical cancers. It also showed a similar hazard ratio for the less than 2 centimeter cervical cancers, but it was not statistically significant. And that's probably just a numbers issue. If there were a greater number of participants, then it probably would have shown statistical significance. So here's the problem where a lot of individuals have made some, what I think are illogical conclusions that all cervical cancers, including microinvasive cancers, should have open surgery. I mean, you could see how you could come up with that statement from the LAC trial results, but is that really true? Well, let's first of all question if it really is inferior survival with cervical cancer and MIS, why? Is it the carbon dioxide that's used or different techniques? I'm going to show you results on colon cancer, uterus, prostate. None of them have shown any difference in overall survival, many of them in randomized studies between MIS and open surgery. And obviously, I guess central to this question is, why are we so fixated on MIS? Are there benefits to MIS? Because if there aren't, then who cares? Just do an open surgery on everybody. So I think most of you know the answer to this question. There are significant benefits in appropriate hands in terms of reduced length of stay, blood loss, surgical site infections, post-op hernias, post-op pain, pulmonary complications, DVTs, and short-term quality of life. Those have all been evaluated in retrospective, randomized, prospective studies and proven. So let's look at post-op pain. So this is studies from radical prostatectomies. This is laparoscopic and robotic. And you can see in those two studies that I have quoted here, a significant reduction in post-op pain at 1 week versus open radical prostatectomy. And here's data on incisional hernias. And this is for colorectal cancer. So, and you can see that there's 2 randomized studies, one showing a big reduction, the other one a smaller increase, but the net result is, it crosses the unity, so one would say it's not statistically significant, but the impression you have is it's reduced. And that would make clinical sense. Blood loss, so this is endometrial cancer, something we're much more common with, and you can see in 3 studies, significant reduction in blood loss versus open hysterectomy. What about serious short-term post-op complications? This is again taken from radical prostatectomy, significant reduction in that one study in short-term complications. So why is cervix any different than endometrial, colorectal, gastric, prostate cancer? And I'm just going to show you some randomized studies of MIS and colorectal cancer. no difference in overall survival. In endometrial cancer, no difference in survival. 9 randomized studies, these are all randomized. Gastric cancer, no difference in overall survival. And unfortunately, in prostate cancer, while they've done 2 randomized studies, they didn't evaluate overall survival. They just looked at other ancillary things like toxicity and complications. So, is the surgery not radical enough? I'm going to guess this is not the answer, because I think in many cases, the radicality may be a little greater. It's very easy to resect too much uterosacral, cardinal ligament, laparoscopic than it is at laparotomy. So I don't think that's the issue. And if you look at the positive margin rate in the LAC trial, it was really no different. So I doubt that radicality is the issue. Could it be the manipulator? So there are a number of individuals who use various manipulators that go into the cervix, go into the uterus, and theoretically it could be. The manipulator that I've used is sort of all external around the sort of cervical vaginal cuff. It really doesn't go into or really touch the cervix dramatically. And then what I think is probably the most likely cause is what I call careless handling of the tumor specimen. So, if you look on YouTube for robotic or laparoscopic radical hysterectomy, you can see some pretty exophytic cervical cancers that once the cervix or the vagina is completely incised, that specimen is floating around the pelvis for a while, and maybe there's some graspers trying to grab it to pull it out the vagina, and maybe there's a little chunk of this exophytic tumor that is spilling into the pelvis. And that's, I think, my personal belief of what the most likely reason for the excess recurrence and death rate from MIS. So can we address these issues? Absolutely. So, here's the question is, if there's no residual cancer in the cervix, which probably happens about 25% of the time, it's very common when you do a LEAP or a cone and you have a cancer and your margins are negative, you're unlikely to find any residual cancer in that specimen. Does it make a difference how the uterus is removed? I got to believe it doesn't. And what about if it's just microscopic residual? So you have a cervix that looks normal, post-LEAP, post-cone. Does that situation make a difference? And I'm gonna say probably not. There's only one, sorry, that's a mistake from where it says no randomized trials. There is one randomized trial that is ongoing today. That's sponsored by GOG Foundations and Intuitive, and it's robotic only. It's not robotic and or laparoscopy. It's robotic versus open surgery in early stage cervical cancer. And I think there's 3 main criteria in there which are very important to recognize. The first one is that there's no manipulator allowed. So you could use something else, but you're not putting any manipulator in the cervix or in the uterus. The second thing is there's tumor containment. So what I mean by that is you've got 2 choices. You could suture off the vagina before cutting it, robotically. You could staple it. So some people use various staplers to staple off the vagina before cutting it. Or you could remove it, incise the vagina, remove it vaginally, and I'll show you some slides in a minute. And thirdly, all these patients had to have tumor sizes under 4 centimeters. So anything above that is not allowed. I want to point out a couple of things. There have been 3 trials conducted looking at the role of radical surgery versus simple surgery in low-risk patients. 2 of them have, one of them has been published, 2 of them have been reported. The SHAPE trial was just reported at ASCO. GOG 278, of which I'm the PI, we can't report the results until this fall when we have 2-year follow-up, because that's the way the trial was designed. And I'm not trying to, I don't want you to focus too much on the fact that the first 2 trials didn't show anything worrisome in terms of recurrences for non-radical surgery. Rather, what I want to point out is that the vast majority of patients in these trials who underwent hysterectomy had MIS surgery, because the vast majority were done prior to the publication of the LAC trial. So CONSERVE trial, 96% of patients who had a hysterectomy had it done by an MIS technique. SHAPE trial, I don't have the exact figure, but the majority were done by MIS. GOG 278, the vast majority were done by MIS. So it provides some level of comfort that in these small early cancers, it's unlikely that doing an MIS is a detriment to the patient. So again, this is the way you can prevent contamination. You can close the vaginal cuff endoscopically before cutting it below it vaginally. The difficulty with using a stapler, and most of the staplers are metal staples, is that you might have to excise that staple line before you're finished, because you don't want to leave metal staples in the vagina. The other approach, which I do, is number 1. So, if I'm doing a radical hysterectomy in a patient with a exophytic tumor, it's less than 4 centimeters, I'll do the whole procedure laparoscopically except cutting the vagina, and then I'll work vaginally, cut the vagina, and just pull the specimen out. And this is exactly what Christian Kohler has been doing. So, here's a picture of a exophytic cervical cancer. He's using something very similar to what we use in terms of a manipulator that really doesn't go into the cervix or uterus. He is cutting the vagina, but it all comes out vaginally. You can see here on number C in the top right, how he closes off the vaginal cuff vaginally and just pulls it straight out. And that's how we used to do our radical vaginal hysterectomies until MIS came around and we started doing more and more of it laparoscopically instead of vaginally. And so here's his data. And if we just look at the top half of this, disease-free survival. So you can see 5-year, well, there's not available. Let's go to 3-year disease-free survival in the robotic arm in the LAC trial, 87%. In the laparotomy arm in the LAC trial, 97%. In Christian Kohler's results, 97%. And the results are pretty similar if you look down for overall survival at 3 years. Now, this is not randomized data, but it's certainly suggestive that containment of the cancer has a significant role in this issue of recurrence. So finally, I'm just going to leave you with a quote from Winston Churchill. And this had to do with, when the results of the LAC trial came out, people said, well, that's the end of MIS for cervical cancer. Well, I don't think it is, because I think, the real question is why and how do we modify things to overcome this? So thank you. I'm happy to answer questions regarding this.
Thank you very much, Prof. Covens. I think that was very comprehensive. And to the rest of the team, for those who joined late, we apologize for the other presenter who was unable to make it. But kindly let's use this time to ask any questions and at least make any follow-ups that we may have with regarding this topic. So I can start off as we continue gathering the questions. Prof, for those of majority of us who might not be aware of the differences in terms of minimally invasive surgery that we're talking about, when you talk about laparoscopic surgery and robot-assisted surgery, would you say there's any difference between the two in terms of outcomes and how the procedure is done, and especially where cervical cancer is concerned?
So there are some small differences. I mean, certainly robotic surgery has a heavy investment in resource and infrastructure. You know, a typical robot would be in the order of, I'm going to say, $3+ million, which right away, I think, puts it out of, out of this league in terms of access in most of Africa. It then requires, obviously, some surgical expertise. Now, in fairness, the learning curve is much steeper with robotic than laparoscopic. I think that, I mean, I'm obviously a little biased in the sense that I'm really a laparoscopic surgeon. I don't have a robot at my hospital. We are getting one, but I'm not going to be using it. I think that it's probably a little easier to do really morbidly obese patients on a robot, because the robot is doing a lot of the work in terms of torquing on those trocars, as opposed to somebody else's arms doing that. And finally, it's very easy with the robot to zoom in, zoom out, and that's really important on obese patients where your field of view is a little less because there's just so much subcutaneous fat. You could do that laparoscopically as well, but your assistant really has to, move that camera in and out and around a lot. So I think most of the really expert laparoscopic surgeons really feel there's minimal differences in terms of efficacy and morbidity, etc. But I'm sure there's a lot of robotic surgeons who will say the opposite.
All right, thank you very much. Dr. Parkari, go ahead and ask your question, please.
Yeah, thank you very much, Anisa. Prof. Covens, my question to you is twofold. One is the value of sentinel node biopsies and the use of indocyanine green. And secondly, how do we increase the uptake of sentinel node biopsies and the use of indocyanine green in this part of the world? Because I'm sure not many of us are using those tools in the management of cervical cancer.
Yeah, so it's a good question. I mean, I think obviously the difficulty is in relation to the cost. I think these could be overcome. 1 amp of ICG, which comes, I believe, as 25 milligrams, and I can't remember how many cc's. I think it's 10 cc, 10 cc's, I think, is about $100. But what my hospital does, and I don't live in a middle-income country, we basically aspirate 10 syringes, each of 2.5 milligrams, and we freeze those. Now, I can't remember what the shelf life in the freezer is. It does have a defined time frame, but even we don't want to waste, use $100 25 milligram vial for one case that's going to use 2.5 milligrams. So you can really mitigate that cost. I mean, right away now you've taken your $100 amp and you've changed it into a $10 single use each patient fee. And the equipment is not cheap. For us, you need a special camera and filter, and that's not insignificant. But the good thing about that is it's a one-time cost. The equipment will probably last, I'm going to say, easily 5 years. If you were to say what's the main benefits to doing this, I'd say it's a reduction of morbidity in terms of lymphedema. And we tend to underestimate the significance of lymphedema because we don't really ask patients about it. And it gets worse after radiation, and we may not see them after radiation. There may be some improvement in efficacy because you certainly pick up a lot more small volume, either micrometastases or ITC, than you would by routine lymph node processing. However, there is probably a little more involved in the pathological processing of sentinel lymph nodes. You're not going to do one section from each lymph node anymore. You're going to give them probably 2 to 4 lymph nodes total, and they're going to section the whole lymph nodes. And most places, if those are negative on H&E, will also use cytokeratin to pick up ITC and very small micromets. So it does have costs, but I think the problem is that there's very few things we can make progress at without generating some costs.
Thank you very much, Prof. Covens. Dr. Eli, go ahead.
Thank you, Professor. Mine is more of a comment and maybe in the form of a question also, is the findings of the SHIP trial and the CONSERVE trial, just the inclusion criteria of the patients in those two trials is that they had low risk disease. And maybe that's why doing MIS gave those kind of outcomes. In our part of the world, we rarely see that kind of patients who can fit that criteria. Most of them have got 4-centimeter tumors. And so maybe what would be a comment in such a case? Should we subject 4-centimeter tumors to MIS, or we go to the traditional way of radical hysterectomy?
So I think there's a lot of different answers in that question. I mean, as you know, I do believe cervical cancer should be treated by GYN oncologists. Now, it's not that way in Kenya, and people may feel a little offended by that comment, but that's the way I feel. I think there's several options. I probably would say a typical 4-centimeter or more that you're going to operate on. Yeah, I think you should do open surgery. There is data, however, to suggest that if you do cone biopsies and you get, negative margins, that those patients do well regardless how you do them. Whether you then did a laparoscopic radical hysterectomy or an open radical hysterectomy, there would probably be no different. But what we don't want to do is we don't want to do harm. And so I'd say the safest thing in 4 centimeters or more would be to do an open radical hysterectomy.
Okay, thank you. Dr. Frame, go ahead.
Good afternoon, Prof. Prof, my question is, there's concern of spread of tumor because of the CO2 gas insufflation. So what percentage of tumors can spread through this route, and how do you mitigate this?
So I don't think it's the CO2. And I say that because here's the difference. If you look at colon cancer, prostate cancer, endometrial cancer, and gastric cancer, they're all contained. So a uterine cancer, it's usually in the uterus. It's not exposed in the cervix. I mean, very few are. Colon cancers, they staple off the proximal and distal bowel, remove the specimen. Radical prostatectomies, similar. Gastric cancers, the same. But here's the problem. In cervical cancer, and you could envision that 4-centimeter exophytic cancer, that picture that I described, people have been cutting the vagina, and that specimen is now exposed to the whole abdomen and pelvis. And a lot of people, if you look at, as I say, just go search some YouTube videos on MIS radical hysterectomy, and the patients are in Trendelenburg, the specimen's detached, it floats up to the brim of the pelvis. There's some bowel here and there, and people are fishing that specimen out. And my personal belief is that's the main culprit. It's not the CO2.
All right, thank you. Dr. Chemtai, go ahead.
Hi, thank you. Thank you for the presenters. As many of you know, so I'm a generalist OBGYN and primarily a researcher. And I run a research program in Western Kenya, which has high HIV burden, which means you see a lot of cervical cancers. And I would argue that the reason Dr. Ellie and others see 4-centimeter tumors is because there's so many gaps to get women with microinvasive disease with that 1-centimeter tumor to referral facilities. And from my research program, where we do a lot of screening, we have many women with microinvasive disease, very operable. But the challenges to get somebody to get that surgery. And I understand that Kenya, is growing gyne oncologists, and there's a push to have gyne oncologists only gynecologists to do gyne cancer surgeries. But the reality is, the referral hospital in Western Kenya does not have a gynecologist at this point. And so by limiting that only a gyne onc will operate in a patient with a microinvasive tumor or with a really early 1A, really what you're doing, unfortunately, is saying she's going to wait 2 years, because that's sometimes what it takes. I literally had a call this Monday with with women, with a research team, and just getting somebody to elder it. It's really challenging. So, as we think aspirationally, and I know as clinicians, every clinician wants to practice at the top of their license, which means microinvasive, laparoscopic surgery, robotic. But the reality is, the majority of women cannot come to Aga Khan, cannot come to where there's laparoscopy. So if we're going to get that woman that surgery that will save her life, because you'll get her at microinvasive disease, where the nearest surgeon is a generalist OBGYN who, with a 3 or 6 month training, can do radical hysterectomy. We really need to do that in the short term, even as we are building up to do microinvasive laparoscopic surgery. So I believe this strongly because I see women who've been trying to navigate for 2 years. They can't get to a gynecologist. And that's why they get to you when they have a 4-centimeter tumor, when their survival is really reduced. Thank you.
Yeah, so I don't disagree with what you're saying. I mean, I think the microinvasive cervical cancers can be treated by any gynecologist. They need simple surgery. They don't need radical surgery. I don't know, the times I've been to MTRH, and I was just there in March, I don't see long waiting lists to get seen or to have an operation. Now, I think for patients, sometimes they have issues with actually physically traveling distances. And you probably know a lot of these issues better than than I do, but we would see patients from all over Kenya, mostly Western Kenya, but some very east as well. And usually they get seen in a reasonable time frame and operated in a reasonable time frame. So I'm not sure. I see Omengi's here, and maybe he can provide some more information on that.
Prof. Omengi, please take it home.
Oh, thank you, Covens, for that interesting presentation. I will attempt to answer what Chemtai is saying. And thank you, Chemtai, for raising that issue. But I want to differ with you. We really do not have a problem of inability to have people who can do the surgeries. We have a bigger problem of people who do beyond what their skill sets can allow. I'll tell you for a fact that in MTRH, for example, we see many patients who've been done suboptimal surgery by gynecologists in a town that is, say, 50 kilometers away from Eldoret, which is 40 kilometers away from Eldoret. Somebody doing subtotal hysterectomy on a 2B, for example. Do you want to tell me it's because the patient waited and could not get head microinvasive and could not access? No. I'm glad that this forum has gynecologists, and I think we need to introspect and ask ourselves, if your skill sets are this much, why would you not allow that patient to go to somebody else who can do a better job, and you know that the outcomes are obviously better when somebody does the right surgery in a timely manner? We have continued, and I remember this week, we've had a discussion on the WhatsApp group of gynecologists in this country. People complaining of a person in Muranga who has continued to do those subtotals. Is it really an issue of lack of access? No. I think sometimes it borders on impunity and lack of feeling what is good for the patient. Remember, the first thing, any patient who comes before you, you must ask yourself, am I doing the right thing? Is it good for this patient? Because even our oath does say, do no harm. It must be about the patient. It must not be about Omenge. It must not be about so-and-so. It must not be about what I'll take home out of doing that surgery. It must be outcomes. And there are many studies that have shown that actually patients, as Covens said, oncology patients operated by gynecological oncologists, the outcomes, overall survival, disease-free survival, are better than if they're operated by generalists. So this is 21st century. We are not in the 20th century, so that we start saying, let us have poor medicine for poor country. We have trained many gynecological oncologists. University of Nairobi is training, Moi is training. I don't see a reason why you should want to say, for wanting to be nice to somebody, just give them a subtotal hysterectomy. It can't work, and it shouldn't work. Thank you.
And I think maybe to echo what Prof. Omengi is saying, we'll find that most of these patients who've been given suboptimal surgeries, majority of them were operated on in private facilities, not even the public facilities. And so it means that the patients, as much as cost can be an issue and an inhibiting factor for some of these patients, they still do end up paying quite a bit to be operated by someone who oversteps their bound. And so this is something that I think as Kenya, we need to improve on. I think I've had patients who've had 1B3, even 2A surgeries being done laparoscopically, then they come back with peritoneal carcinomatosis or even remnant disease, and they still need to undergo radiotherapy, which is not very good. It's very harmful to the patient to have those kind of co-treatments. And then I'll let Julius Nkalubo speak. Please go ahead. Julius, are you still there?
Are you still there? Yes, I'm here. Thank you, Anisa. I'm from Uganda, UIN ONC, IGCS trained. Issues. One of the
criteria that right candidate for minimal invasive is tumor size less than 2 centimeters, but I don't know which technique was used. Most of the cases, they do at least a CT scan for the metastasis workup and estimating size. So I'm wondering if at all laparoscopy becomes more accessible, can we match the standards of selecting the right patient? Because I believe even in Kenya, you use the estimation of a 2 centimeter tumor mass. So is there a more acceptable way of assessing size and say, okay, this is reproducible, a 2 is a 2. Otherwise, my
Julius, you're breaking up quite a bit.
So I would say there are, if all you're trying to do is measure tumor size in an objective fashion, that's not to say that clinically
touch criteria. The second issue is from the colleague who was
Julius, you're breaking up quite a bit.
sorry.
So the only comment I was going to make is if what you're trying to do is evaluate the cervical cancer size, there are a number of ultrasonographers who are very good between, pelvic ultrasound and transvaginal ultrasound in giving you a tumor size. Now that's not going to help you with respect to parametrial involvement or lymphadenopathy, et cetera. Whereas certainly an MR scan would, but I realize that's a whole different level of expense. But clinical measurement isn't terrible either, as long as you're experienced and you can feel it well. So there are ways to get around the tumor size issue. It's not going to help you with respect to identifying any lymphadenopathy, but to tell you the truth, if you've got a true tumor size that's under 2 centimeters, the likelihood of seeing grossly enlarged lymph nodes on any type of imaging would be small.
Dr. Pakar, you're back. You can go ahead.
Basically, not related to Prof. Covens' presentation, but what you said, Anisa. If people continue to do suboptimal surgeries for tumors, what is COGS and the Kenya Medical Practitioners Board doing about it? Because if these issues are consistent, I think somebody should police these issues so that they are not repetitive. The second issue I wanted to raise, I've been practicing gynae for the last 30 years. Every new patient that comes to my office has a first contact PAP. Now, if we try and encourage that sort of thing, do more PAP smears or VIAs so that we pick these tumors early, so we don't, in time to come, we don't have to deal with 4 centimeter and 6 centimeter tumors. That's the way it is in Europe. In Europe, you don't see advanced tumors. They are picked up very early. So why can't we aim to reach that destination? There are so many gynae-oncs now in the market, which is commendable. But prevention is always better than cure. It's just a comment. Thank you.
Thank you, Dr. Pakar. Dr. Finn, do you want to respond to that?
Sorry, not particularly to that, but I want to ask a question. You can go ahead, Anisa, and respond to that, and then I'll carry on with my question.
All right. I'm actually going to pick on Dr. Eli as our President Emeritus to tell us about what is COGS doing to all these people who are doing surgeries that is beyond their scope and they're doing the wrong things. And then I'll also ask Dr. Covens to tell us what happens in Canada to such individuals. Ellie?
Thank you, Dr. Anisa. I'm a retired president, so I may not really purport to speak for the society now, but learning from previous experience is that our society is our professional association registered under the act that governs voluntary kind of membership. And this actually has handicapped the ability of the society to bite, so to speak, to give it teeth to bite, because it's more of a voluntary association. It's not a regulatory association. But now that we have a seat in the Kenya Medical Council, then I think that's where now we'll be able to inform practice. In addition, we have just gotten a nod from the Register of Societies to register the Society of Gynecological Oncologists in Kenya, and I believe that this will set the standards of practice in gynecological oncology in this country. Thank you, Dr. Anisa.
Thanks, Ellie. Prof. Covens?
Yeah, so I think, as Ellie said, all of these professional societies, whether they be ASCO, SGO, COGS, etc., are professional societies that have voluntary membership and are used for perhaps setting standards, making recommendations, etc., but they have no regulatory capacity. So, you know, in most you know, first world or developed countries. So I can, you know, think of the United States, Canada, Australia, the UK. There's two processes that can positively impact physicians who are kind of either repeat offenders or are not keeping up with standards of care. One is obviously litigation. Now that may not happen as often in Kenya as it does in North America. But, you know, if a patient has, people use the case of a subtotal hysterectomy for a 2B cervical cancer, I mean, that's clearly inappropriate and that would be indefensible. So that's one method. And then probably the more important or more significant is the college. So I believe Kenya has a college of, I'm not sure whether it's called College of Physicians and Surgeons, but they're responsible for upkeeping, upholding the standards, protecting the public. And those people have the ability to take away licenses. Now that would be the most egregious penalty. Many times it might be recommending additional training, restricting types of work, etc. But those are the people who have the biggest authority.
Dr. Afrin, you had your hand up.
Thanks, Anisa. So, Doc, just an addition, even for the low-risk patients who, looking at the CONSERVE or the SHAPE trial, who can get a simple hysterectomy, there's a specific criteria that you need to follow. The other thing is, in order for you to offer, you at least need to do a con biopsy. You need to assess the LVA size. There are many factors that you need to do. Now, my next question goes to Dr. Chemutai Mungo. In as much as we do not have access to a lot of gyne-oncologists, does that mean that we offer suboptimal surgeries to our patients and then we do damage control? Or like in the case Dr. Okello just asked, that we don't have access, certain patients don't have access to endometrial biopsies. So do we bypass all that and start offering them very radical procedures? What are the implications of these or suboptimal or radical procedures in the event the patients don't have that extensive disease? And or if they have an extensive disease and we've offered these suboptimal surgeries, what are the implications on a long-term And in Kenya, currently, we do have 21 gyne-oncologists with a number still in training. I believe there are referral pathways which we can follow. And I think these are what are being bypassed. In Western Kenya, there are 2-3 gyne-oncologists. In Mombasa and the coastal region, we have 3 gyne-oncologists. In Nairobi, Eldoret, we have quite a couple. So why not establish a good referral pathways? Even communication, why not communicate with these gyne-oncs before offering all these suboptimal surgeries? Because the implications are drastic. And this we see in our patients that we see at MTRH. So how do we tackle that issue?
That's a complicated process. I mean, I think my impression for most of the times I've been to Eldoret, including, this spring, is there is more capacity there for the gyne-oncs. There are some cases that the gyne-oncs are doing that they probably don't need to do. And by that, I mean that they're high likelihood of something turning out to be benign. Those are cases that we wouldn't do. We send to the general gynecologist. So I think there is capacity in the system. Now, getting the patient there is a different obstacle, and I recognize it is an obstacle. I think it would be way cheaper for the hospital to pay for the endometrial biopsy than do some procedure that includes staging, etc., when a proportion of those patients really didn't need it.
Yeah, that's true. Dr. Chemtai, you had a response?
Yeah. So for sure, nobody wants, the person doing subtotal for patients with an obvious tumor is not what we're discussing here. Nobody wants, suboptimal surgeries. There are certain cases of early stage disease, including microinvasive, where general gynecologists can do the cases. The question is, are we appropriately triaging so we're not sending all cases to Eldoret, to Kisi? So currently in Kisumu, the gynecologist is not operating because he's in administration. So, for all the women in Western Kenya who are being sent to GTRH, are we optimizing the general gynecologists there to do the surgeries that can be done that are early cases, and not just sending everybody who has microinvasive disease to a gynecologist, and then they have to wait 6 months or don't get transport? This is where we're talking about, Dr. Okello's patients. I think, that's a different context. And ideally, if the system was more robust or holistic, would say, it's cheaper for the hospital to pay for the endometrial biopsy, to guide management rather than do, a case before it. So I think we're talking nuances here, and it's not just, it's criminal for somebody to do a subtotal. That's completely different. The question is, do we have clear standards so that, all the people in the periphery, so like Dr. Lungesa was saying, outside of Nairobi and some, Eldoret, there's very few gynecologist. So do we have clear standards? And ideally, this would be a document that's put together by the gynecs. Like, these are the clear standards of who can be operated, who can get, a simple hysterectomy, who can get a radical hysterectomy. And ideally, for early disease, we, potentially put together metrics of, who is trained to do a radical hysterectomy and who is not a full scope gynecologist. I know, there's turf issues, but I think those are some of the things that can really make a difference for women who can't get to the periphery, to the central locations.
Well, I think it's more than just a tough issue, and it's what we are seeking for the best treatment for the patient, so that we avoid any recurrences And I think I'd really recommend for the team to go to the IJGC website and listen to the podcast by Marie Plants on the SHAPE trial. And one of the things that really comes out in her conversation with Dr. Pedro Ramirez is that it is essential for gyne-oncologists to manage these patients, because it's not sometimes just about doing the surgeries. Most people can do a surgery, but there's some things that we look at that might not or might escape a generalist or someone who's not trained particularly in that field of gyne-oncology. And I would really like to listen to Francis Githai. You have an excellent point about the UK. Please go ahead. Dr. Githai?
Yeah,
There you go.
I was muted. Yeah,
Sorry.
hello everyone. It's very exciting listening to the discussions that we are having today, and I really don't have much more to add. You all have, brought out the key issues. But one key thing that I'm thinking about that is relevant to our context is, even if we are saying that we have 20-something gynecological oncologists, how many of them are found in public hospitals? We might be training gyne-oncologists who the government is not absorbing, and then they end up in the private sector, and only women of a particular group can access their services. So I would really be very much interested to know the 20-something gyne-oncs, where are they? And then the next question would come in also, for us to quantify the issue with access. Yes, they might be in the hospitals, but how many sessions a week are they operating? Are they there full-time, or are they there part-time? All those are very key questions to think about. The other ones I've already highlighted, the value of a national cervical cancer screening program. I'm happy to hear that there is now a gyne-oncology society that is coming into being. So I hope there will be an advocacy body for us to set up a national cervical cancer screening program. And lastly, it's about accreditation. We are talking about accreditation of people to do gynecologic oncology procedures, either as gyne-oncologists or people practicing with an interest in gyne-oncology. But can we take a step backwards and think about even colposcopy and those aspects that support screening and management of early disease? Do we have a program that tells us those people that are doing colposcopy, what is their skill set? How do they maintain their competency? All these are questions that I would really wish that we think critically about. Lastly, I think that if we want to change the future, we have to look at our specialist training programs, both the general one and the subspecialty ones, and inculcate a culture of professionalism and people following the limits, and also bring in the culture that when you call for help, it doesn't mean that you are a poor OBGYN. The best OBGYN is one who works in the setting of a team, collaboratively with others. You can call for help, you can refer, and these are strengths, not weaknesses. So we need to really inculcate this to the current trainees, because those are the future. Thank you.
Thank you so much, Dr. Githai. And you do bring a lot of points that we've been discussing that's facing us as a country. And maybe one thing that I will say, we will follow up with mapping out where each of the gyne-oncologists in Kenya are located, because we've had several of us being called to different hospitals to go and operate there. So you just set up cases and we show up. So like Dr. Githai says, now to the whole team, please, if you do have cases, you're free to consult with us. You're free to call us and we can help operate on these patients or guide you on what you need to do, and we can do it as a team. So we are on top of the hour, and I want to be respectful of Dr. Covens' time. Are you okay? We take one or two more questions, Prof?
Sure.
Awesome. So I'll go to Julius Nteziare. Yeah, I'm sorry, I'll butcher your name. I'm really sorry. Julius, I think you're from Rwanda or Uganda. Go ahead.
Hello, thank you, Dr. Nisha and team for the discussion. This is Julius, as you said, fellow at Uganda Cancer Institute. This is a timely presentation. I have two comments to make. One will be, I may have missed it because I came in a bit late. I'm sorry, but I'm asking when it comes to classifying this patient as a patient with high risk factors, because we are saying that we are leaving out the parametrium. If we're doing simple hysterectomy, then do we shift and have to look at the edges of the parametria as at the positive margins. Look at the vaginal edge, but also go to the parametria, part of the parametria as positive margins in that case. Hope that is clear, hope I'm clear on there. So the second point I wanted to make is while I was listening to Kenya, I said deep inside I was like, these are typical East African problems, typical Ugandan problems. Because much as I listened to you discuss, you have much more gynecologists than we have in Uganda, but largely interesting, all of the gynecologists in Uganda are almost in public hospitals, not private hospitals. And our patients who get those suboptimal surgeries come largely from patients who have paid something, and much more, especially in the private, expensive hospitals. And the ones who have come from public hospitals have also had underhand payments for them to have that surgery. In fact, if you don't have anything to pay, you will be sent to the right persons than if you have something to pay. So that's why I come in and say, the issue of transport may not be a very big issue. The issue has got to be back to our attitude. And I love what the previous speaker, I didn't get the name right very well, but what the previous speaker said, being able to refer is a strength, knowing your limits is a strength. A good doctor is done works within a team. I think this problem is cut across East Africa. We need to do more in our professional bodies. We need to do more in trying to inculcate the culture of professionalism. These are typical problems that we have in Uganda as well. Thank you very much.
Okay, thank you so much, Julius. Prof. Covens, is there anything you want to respond to that before we go to Nelly Bosire?
No, not really. I didn't really think there was a question in there.
Yeah, for sure. All right, Dr. Nelly Bosire, please go ahead.
Thank you so much, Dr. I think for me, my comment is more of a comment rather than a question. And I feel like we're all kind of struggling. We're talking about we need policies, we need guidelines, we need to have guidelines on how to screen. We have all these things. They exist. So where is the gap? First is that we're not putting effort to implement what we create. We know Kenya is the country of great policies that gather dust on the shelves. Kenya has had a screening policy for cervical cancer, for instance, for more than a decade. So we basically just need to say where we work as gynecologists in our departments, are we willing to put our foot down and say we are going to follow the existing national protocols? Because that will be a good start. The second thing is that it's about advocacy. When we decided that pregnant women shall not die, yes, I know they're still dying, we said they were going to provide free maternity. Have we decided that women need to stop dying of cancer? Because I don't understand in this era we live in with access to NHIS, why our patients must suffer with cervical cancer, for instance. Are we in a position as advocates, as the patient advocates first and foremost, to say, can we lobby that for every patient diagnosed to have cervical cancer, irrespective of where they are, they get automatically enrolled onto the NHIF platform and they get into the care system? Patients don't refuse referral because it's too far. Patients don't refuse referral because they don't want to see the gynecological oncologist. They simply can't afford it. And we waste a lot of money back and forth telling them to keep coming and going because our public health system is also a little inefficient. If a patient comes today to be screened and she's found, you take a specimen for pap smear, how long does it take for her to get results? Another 4 weeks. Then you decide now we need a biopsy. How long does it take results? Another 6 weeks. So we're losing time on the patient, but this patient in a private facility will get her pap smear report within 24 to 48 hours. Her biopsy will be done within a week. She has a full diagnosis and she joins the care system. How do we advocate to change this? NHIF pays for cancer care. How many of our patients know that? What is the biggest hindrance when we give them a 2-month waiting period? Do we have a process, or can we advocate for how to facilitate this to reduce the burden of cervical cancer in the first place? I think if we advocate for removal of the waiting period, particularly when it comes to cancer care, not necessarily anything, but at least for cancer care, I think it will give our patients hope. It will give them a chance. They can struggle to raise 6,000 shillings, get enrolled and get onto the treatment plan as they continue to figure out how else to deal with the costs that arise out of that. And I think in terms of care, I think our constitution is very clear. Patients should be afforded the highest attainable standard of care. We have so many gynecological oncologists. The truth be told, at least from the ones I know, majority of you are actually in the public sector. Yes, you serve the private sector, but majority of you are actually the public sector. So we don't have an excuse. We cannot have a cancer center in every sub-county hospital, but we do know that we can have referral points. And when those referral points are clear and defined and patients do not feel lost within the institutions when they show up for cancer care, it will go a long way. Kudos to KNH. Their processes have drastically improved in the last decade. Patients do not wait on corridors for weeks on end to get into the care system. Can we replicate this efficiency everywhere else? KUTRH has started really well. Can we make sure it stays that way? Because I think we can't blame patients sometimes when even us on our part, we haven't done enough to advocate for the system to be a lot more responsive than it already is. Thank you.
Thank you so much, Dr. Nelly. I think those are very, very important points, and there are things that we really need to consider. So I'll take 2 more questions and then we release Prof. I'll start with Dr. Itsura. Please go ahead.
Thank you so much, Dr. Anisa and group, and special thanks to Professor Covens for having weathered all the storms and come to help us here in Eldoret. Now, mine was just an offer, which is a continuing offer. Anybody in the western part of Kenya who has gynecological patients that can be operated on, we can always offer that help, and we can actually travel to those facilities, public facilities, and do the surgeries there. For example, today I've just been from Webuye, and I've done several lip procedures. So the patient Dr. Okello is talking about in Kisumu, if she can organize this week from tomorrow, we have 3 of us in Kisumu. So we can easily come and operate. Dr. Tonui, Dr. Isura, and Amina, we are going to Kisumu tomorrow for some other function, but we can still operate that patient at JOTRH. That's the name, yeah, Kisumu, if the patient is prepared for us. Thank you.
Thank you so much for that, Dr. Itsura. I will add on, I also go to Kisumu every month. And so if anyone needs surgery, if you contact me, find out my days, I can come and assist in any of your surgeries. Dr. Njagi, please go ahead.
Okay. Good evening. Can you hear me?
Yes, we can hear you.
Oh, excellent. All right. So thank you so much. And this is a very interesting conversation. So I'm Dr. Njagi. I'm a general gynecologist biased in minimal invasive surgery. And I think the conversation is quite interesting, as this was to be minimal invasive surgery in cancer of the cervix. But, it feels like the problem locally here is much bigger than we actually thought initially. But I just want to go back again in relationship to minimal invasive surgery, and this is to Professor Covens. And this is just to kind of pick your brain on this, and you can correct me if I'm wrong. From the LAC trial, and I think I've picked this up, the 33 centers which were enrolled, it was found out that 14 of them are from South America. And these were found, the 33 recurrences that happened out of the 36 recurrences was actually from these centers. Do you, and I really like how you put it, careless handling of the specimen. Do you think if this had to be redone again, whereby the surgical technique was standardized and picking up centers that had high volume? I'm not sure how many of these centers had very skilled, open gyne-oncologists who are actually equally good in minimal invasive surgery. And if control was taken on spillage and use of manipulator, do you think that this would take a different direction?
Oh, absolutely. I think, I mean, that's really what the robotic randomized trial is doing. It's specifying no manipulator, vaginal containment of the cancer. So absolutely. I don't know the exact details of the centers involved in the LAC trial, but I thought that it didn't appear obvious that a lot of the recurrences came from specific centers. I mean, there were people who wrote in who said, you know, in my hands, I don't see any recurrences. And then when you show that individual his own data that, yes, there are some recurrences, then people all of a sudden, oh, yeah, maybe, yeah, I forgot about it. So I don't know if it's a center type issue as opposed to just principles that people haven't thought about in the past.
Okay. Thank you, Dr. Njagi. Dr. Tanui, then Prof. Omenge.
Thank you very much for giving me opportunity to make a few comments. And thanks, Professor Covens, for a good presentation. I take a more positive look at the things as they happen in our country. I think we've made a lot of strides. We have a national immunization program that we didn't have, and our girls who are 10 to 14 years old are being immunized. I think the uptake is not as good, but we can make effort to improve on that. Cervical cancer screening is really like generally improving in our country. In Western Kenya, we have a large screening program. It's a regional screening program, and we are inching towards having over 200 women being screened here. So I think there are positive things that we are doing. We are training a lot of gynecologic oncologists. And as we said, like maybe 10, 15 years ago, we had only one in our country. And now we have 21, probably about 10 in training. So very soon we'll have gynocs all over our country. And radiation services are also becoming available in our country. I think about 10 years ago, we had only one machine in Kenyatta, and now we have probably 5 or 6 across the country in public sector. So things are looking up. We need just to to correct ourselves in what we are doing wrong, and I think oncology services will be better in our country soon. Thank you very much.
Thank you for those comments, Dr. Tanui. Prof. Omenge?
Sorry, I want to debunk what Jackie has said. One, I think let's be fair, when you're commenting about a paper, a publication, or a study, you get your facts right. Yes, there were 33 centers. Yes, there were 14 centers that had recurrences, but indeed they did sub-analysis on the recurrences, and there was no systematic or certain ways to indicate that the recurrences were pointer to either the lack of skills of the surgeon or the facility. Remember, before a center was accredited to participate in the LAC study, there were things they looked at. You had to have a high volume of patients doing laparoscopy, and no single surgeon was allowed to only do either laparoscopy alone or open. And so, indeed, that's not true in Njagi. We can look at the data again. Thank you.
And maybe this will be a great point to bring this up for the team. Because of all the conversations we've been having over the last couple of weeks, we got to invite Professor Pedro Ramirez, who is the PI for the LAC trial, to discuss with us about the LAC trial. So we should be able to ask him all the questions that we have and any of the problems that we have with his paper, plus any advantages that we think we can garner from it. I also specifically invited Rene Pareja, who was also involved in the paper, and he is specifically from a South American site. And so he will give us at least views as to how the South American sites handled this particular problem of recurrences and can debunk any myths or any misconceptions that we have about the LAC trial. So please put this on your calendar, July 26th at 7 p.m. East African time. You're all welcome. Even Covens, please, if you can join us, please, it'll be lovely to have you. So we have gone way beyond and above our time. And Prof. Covens, really thank you for your patience with us. I know there's still so many questions in the chat. I've not even had a chance to go through all of that, but I think we'll keep communications. I think the key message that has come out of it, patient selection has to be excellent, and we have to be very good at it. Know which patients need to be operated on and by whom. Let's follow our guidelines. Let's try to get these patients better access. As we said, we have a lot of gyne oncologists from Nyeri, Eldoret, Kisumu, Mombasa, Msambweni in South Coast, Kisii, we have Dr. Gitari there. We are spread out, and Garissa soon we'll have Dr. Amina. So we are spread out around the key centers in Kenya. So please, people, use us, utilize us. We are there for you. And so I'll call this meeting to an end. Prof. Covens, again, thank you so much for giving us the talk and being there for the questions. And everyone, thank you so much for your active engagement, for showing up at 8 p.m. all the way to 9:15. It has been lovely. I truly appreciate this. May you have a lovely, lovely day and the rest of the weekend. My week has ended, all right? Thank you.
Thank you.